Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy you chose to spend this hour with us, and we're going to jump right in on our conversation today around a subject that is very important to and in our community. Without further ado, I turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Davis Stevens, my long-term friend, and happy birthday to you.
Oh, it's
So,
not yet. It's next month.
well, it's here. We accept it now. Well, if you notice, for the past few months, we have hammered certain topics several times. And I know any of you who've done any kind of work driving in nails, it takes more than one hit of the hammer to get the nail where it needs to be. But it's super important not only to eat right, to have the right foods, but I don't want people to get the idea that little things don't hurt. A little bit of blood pressure can be very dangerous. A little bit of heart disease can be dangerous. A little bit of protein in your urine can be dangerous. These say that there's something deeper to this fact. And I want to today go over the guidelines and talk about a few changes that have been made and hammer why it's important to do this. Let's go to the first slide, please, Simon. And Dr. Neighbor Stephen, you and I'll do this together if you don't mind.
Certainly, Dr. Hines has joined us.
Hello, Dr. Hines.
You're on mute, Dr. Hines.
Can you put that on the large version, Simon? Okay. So we're going to talk about hypertension and update on the diseases called hypertension, CKM, which is cardio kidney metabolic syndrome risk in African Americans. And this is from 2025 update, and information comes from the New England Journal of Medicine, from the Journal of the American Heart Association, Circulation, and from the Journal of the NMA. Let's go to the next slide. So there are cardiovascular disease risks, and this is also about mortality and management. We want to keep everybody here and want to compare this, what happens in African Americans and with the US population. Next slide. So as an overview, Dr. Neighbor Stevens, would you start this one?
Sure. Cardiovascular disease, otherwise known as heart disease, is the number one cause of death in the United States. Now, it's called cardiovascular because it involves both the heart and the vessels, but I wanted to make sure we were all on the same page. Nearly 1 in 2 adults have some form of cardiovascular disease, and in African Americans, they have a higher rate of hypertension, stroke, and chronic kidney disease. Now, our goal today and in all of our sessions when we talk about conditions is to highlight the risk, underline ways we can prevent it, and identify treatment advances as they come.
Next slide. Can you change that, Simon? So how big is the risk for cardiovascular burden? Well, we do know that there's more than 33, there's more than one person that dies every 33 seconds. That means over 2,500 people per day. So there's a prevalence of 58% versus 49% in whites, Asians 45%, and Hispanics 39%. We want to control blood pressure ahead and earlier than we used to think it should be done. And there's less control of the blood pressure in blacks than there is whites. For example, there's only 25% control in blacks who are on medicines, as opposed to 32% of whites. So it's important that we have aggressive screening and team-based management. Next slide. So, Dr. Hines?
Sure. So cardiovascular deaths. In 2023, there were almost just under 1 million cardiovascular deaths. I can't see the x-axis of the slide.
It's 1.8 at the bottom left.
No, I'm saying oh, there we go. There we go. There we go. So, okay, per year, right? And
Yeah.
then, so almost 1 million deaths per year. And then there were 76,000 or so per month. That means 2.5 people per day, 106 people per hour, and almost every 1.8 minutes, there is a cardiovascular death.
That's saying people are dying while we're talking, right?
Yep.
Mhm.
As a matter of fact, multiple people are going to die from cardiovascular disease while we're on this meeting.
Next slide. If you can take this one too, you're so beautiful and good.
Sure. Hypertension, high prevalence and low control. Give me a second. 58% of Blacks or African Americans have high blood pressure, but only 25% of them are controlled. And this is what Dr. Maxey was speaking to earlier. And I think in general, what you see, that's a trend across all the slides. And I think where that ultimately kind of lies is two places. One, people get really complacent about better, right? They were 180 over 110, and then now they're at 150 over 82, and they're like, woo, I'm so much better. And then we kind of get stuck at better and don't always get to the goal. And then what you can also see here in this slide is 49% of Caucasian people have high blood pressure, but only 32% of them are controlled. 45% of Asians have high blood pressure, 19% of them are controlled, 39% of Hispanics have high blood pressure, and 25% of Hispanics are controlled. And I think, again, I think this is a multifactorial issue, and some of it is guidelines. Some of our providers have not updated ourselves on what the actual goal of blood pressure control is. There's a lot of things that have changed based on age, and then there's a whole lot of discussion going around now about changing recommendations based on race, and that a lot of things contribute to that disparity between prevalence and control.
Excellent, excellent. Next slide. You might as well take this one too.
Yeah. So stroke and heart failure hit harder. So I can't quite, you did your best, Simon, but I still can't see the bottom of the slide. There we go. So Blacks are 3.8 times more likely to have end-stage kidney disease than whites, right? And these are having end-stage kidney disease, strokes, heart failures. These are manifestations or how cardiovascular disease or disease of the blood vessels in your heart show up in other aspects of your body, right? So in heart failure, the blood vessels that are feeding the muscles of your heart, well, they're not getting the nutrients and the oxygen and all the things that they need. So then your heart literally that muscle does not work effectively. And then heart failure. Stroke, if you've got disease in the vessels of your heart, then you likely have disease in the other small vessels. And that's why end-stage renal disease or end-stage kidney disease runs hand in hand. And then stroke, the blood vessels, the teeny little blood vessels in your brain are also impacted as well.
That's a very important point you just made, Dr. Hines. For example, when I was a fellow, it was shown to us that by the time you have a little bit of protein in your urine, about 10 years after that, you get a problem with your retina. And shortly after that, you get a problem with your kidneys or detectable. So it is very much a problem with the little capillaries and blood vessels that they leak, and there are problems with inflammation at the basement membrane level. So let's go to the next slide.
So major risk factors. Hypertension is certainly the most common, and this is especially true in the African American population. But other things that are risk factors for heart disease or cardiovascular disease are having a diagnosis of diabetes, as well as prediabetes. And then I will also, just to be clear, even controlled diabetes is still a risk factor. Chronic kidney disease, which is CKD, cardiometabolic syndrome. That is that combination of what used to be just called metabolic syndrome. It's that combination of high cholesterol, having a waist circumference that's greater than what it should be. What else is in there? High blood pressure. Again, additional risk factors are smoking, obesity, stress, poor diet, and physical inactivity.
And while we're on this slide, I want to go to a question to Dr. Neighbor Stevens. I read something that the main group at risk for diabetes and mortality, early mortality, have to be younger people, teens about 18 years through 50. So but you mentioned many times that many of our kids now are developing not juvenile onset diabetes, but diabetes due to obesity. Is that correct?
That is correct. That is correct. And if it's not type 1, even though type 1 or used to be called juvenile diabetes is usually pretty dramatic in its presentation and onset, you can smolder along a long time with type 2 diabetes. And so unless you're looking for it in the younger population, you won't find it. But bear with me a minute. As you were going through the 2 slides ago, I think it was, when you were talking about stroke, and I had a flashback to, as many of you know, my father was a minister, and I just had a flashback to one night in the middle of to me, it seemed like the middle of the night. And I had been in bed a long time, that's for sure. One of the deacons in the church, his wife called distraught that he had collapsed and she wasn't sure what was wrong with him, whatever, whatever. And so my mother and my father had to go. And because it was in the middle of the night, well, because my mother had to go and, it was the middle of the night and we were home, my brother and I had to tag along. And this was not a unique, I won't say it was every week, but it was not a unique experience for my father to get a call. And it seemed like they were always at night, but not always. Somebody had had a stroke or somebody had had a heart attack. And back in those days, the risk factors that we were just talking about, smoking was much more predominant than in everybody's community is not just our community. Obesity was common, and with our lifestyle habits, even though people weren't checking cholesterols at that time, I'm willing to bet the cholesterols were pretty high as well. So I'm reflecting on this because it almost took, in a way, to me, these statistics and these nice adjectives that we're using describing all of this is all true. But I just hope people are relating to what we're really talking about. I guarantee you, if you look around a group of African Americans, even if you haven't had a medical training, you can probably guess who's got what.
That's very interesting. I recall I used to make a remark to myself in church. I never say it out loud. If all the women over 45 or 50 on one in the church got on one side of the building, it would tilt. Because back in the days, it was fashionable to be more healthy or heavyweight, so to speak. And people did not understand uh, the dangers of obesity. I remember on Sunday morning, I'd have to put my foot on one of my aunt's back to strap on her corset. And I haven't seen a corset for a long time, but it seemed that we were a different group then. Let's go to the next slide, and Dr. Neighbor Stevens, you can take that if you would.
So we're going to talk about some treatment advances that have come along in the area of diabetes and obesity management. We are bombarded these days by advertisements for the GLP-1 receptor agonists. Um, I won't call any trade names, but y'all know what I'm talking about.
You can
That
call them. Doesn't matter.
were
Patient education.
that initially were approved for weight loss, but have demonstrated that, I'm sorry, they was initially introduced for glucose control, but it was noted during the trials that there was weight loss associated with the treatment, and now even more of even now even more effects have been identified um, that lead to improvement in cardiovascular status. SGLT2 inhibitors have been identified to help with maintaining kidney health and protecting the heart. Non-steroidal MRAs, such as drugs that you would probably not recognize by these names,
Corindy.
finerenone or Corindia. Uh, these are handy tools for Dr. Maxick because they help to reduce proteinuria and slow the progression of chronic kidney disease.
So
And
going
we
back up to the top, Doctor, the GLP-1s, one of the most famous ones is known as Ozempic, and there are several other ones that fit in that same category. And their main indication is they decrease heart disease, strokes, cardiovascular disease in general. And part of the way they work, they make you pee out the excess glucose, and they help reduce insulin resistance. So that's one of the main things they do, and all of them do that. In fact, I read an article this week that showed that you can actually, by a combination of these medications, reduce insulin resistance back to where there's no insulin resistance, which may be at the heart of a lot of this. And we know that the non-steroidals that she was speaking about help reduce inflammation. That's how it reduces the proteinuria in the kidney. So these are very, very important things, and we'll speak a little bit more about them later. Let's go to the next slide. Dr.
stroke,
Hines,
chronic kidney disease, and pre-diabetes. As we've addressed earlier or identified earlier, in the African American community, there is a 50% higher rate of strokes. And we'll talk, there are two types of strokes. We'll get into that in a little bit because it is important to know about the differences. Chronic kidney disease is 3 times more common in African Americans. And Dr. Maxey, I'm going to throw it back to you after I read the next 2 lines. On this one, is it the chicken or the egg? In pre-diabetes, approximately a third of U.S. adults are affected. Pre-diabetes means that they have a hemoglobin A1C that is just below the cutoff point for the definition of diabetes. Early detection and lifestyle change are critical. So my question to you, Dr. Maxey, is chronic kidney disease, 3 times more common in African Americans.
yeah, there's several things that occur there's first of all, there's a genetic variation that occurs in 13% of African Americans who have a history of coming from West Africa and the places where the tsetse fly lived. And that was done 10,000 years ago. And it's a reason that we need to screen people for that. That's one thing that makes our rate of CKD higher. In addition, there are a number of other factors that kick that into activity. And those would be things like diabetes, hypertension, lupus, HIV disease, which can exacerbate that and make that gene variation actually come into action. In addition, uh, Black people tend to be more salt sensitive. Again, it had to do with the Middle Passage. And there has to be more inflammatory reactions in those people that get CKD, and it's shown in the eyes and the brain as well as the kidneys. And I think also be shown very shortly that it's high in those that have pre-diabetes, not just diabetes. It's a continuum. So I think the chicken and the egg get created at the same time, Dr. Neighbor Stevens.
Good.
Can I just make a comment about pre-diabetes? Because I think while I appreciate that this is a term that we introduced, because there is that space between I don't have diabetes and I do, but lots of people get stuck with pre-diabetes and their body has moved on to diabetes, but their mind is stuck on, I still have pre-diabetes. So in addition to the hemoglobin A1C, something that you might be more familiar with if you aren't actively being tested with a hemoglobin A1C is that fasting blood sugar. If you're getting a fasting blood sugar of 102, 108, 109, right? You need to take that seriously, and that is consistent with pre-diabetes. I think, again, sometimes as providers, we don't pay attention to those things that are just above the normal, because it's supposed to be less than 100, that fasting glucose, but it matters. If it's 104 or it was 110, those things matter. And that's that pre-diabetes space that I think oftentimes gets overlooked.
I think that's a very good point you make there.
May
And
I may I ask that we do something at this point as well?
yes,
We have an OBGYN on, and I wish she would just comment on the impact of these types of chronic diseases on our overall Black maternity, morbidity, and mortality.
well, yeah. Who is it? Who's on?
Dr. Edith Smith Rayford is on.
Hello, Dr. Rayford. We enjoy your comments.
Well, thank you, thank you. It would be my professor and teacher, Dr. Barbara Naybrit Stevens, who would call on us, and even at my Harris, she would call on us and say, "Whenever I call on you, just be ready." I was not prepared, but at the same time, we're dealing with something particularly formidable in the African American community, and it's really a long act has not yet been evaluated. Young African American females in childbearing age groups, I am seeing more gestational diabetics, which is diabetes related to pregnancy, as well as patients who are already diabetic, not to mention patients who have had a history of hypertension and still have hypertension. What eludes me is just as Dr. Hines has stated, when patients that I see, maternal patients, they've had gestational diabetes in pregnancy, they feel as if, oh no, that was just pregnancy related. I don't have it now. I'll never have it in the future. And that is just not true for most patients. The same thing with hypertension. Oh, I was just hypertensive during my pregnancy, but now I'm fine. I don't need to take medication. We see it more and more, and I do believe that is some of the reason why we have a higher maternal mortality and morbidity state today as compared to, I would say, when we were back in the 1970s, 80s. I do believe, just based on listening to my professors back then and now, that sort of at a better stage with outcomes for African American females. But now, since the onset of the 90s and the 2000s, we're going in another direction.
Let me pose
Do
a
I
question
have
to
the
you.
right The exact numbers, no, I don't have the exact numbers right now, but I can tell you it is a problem.
Let me pose a question to you, doctor. How does this affect the fetus?
Well, of course, babies tend to not tolerate diabetes in pregnancy or fetuses as well as the mom does. We still have that stillbirth statistics. And if we look at a number of stillborn fetuses, and we still are bothered with stillbirths, if we really dive down into it, a number of those mothers actually have or have had diabetes. Those fluctuations in blood glucose is not, for some reason, as well tolerated in fetuses as it is in the mother. Not to say that it doesn't impact the mother, but I'm just talking about the fetus, particularly from my experience. So it is a problem. And not only that, when the child is born on into the toddler stage, childhood stage, there is now evidence which shows that there's a direct correlation with obesity in children. If their moms had diabetes, gestational diabetes, there is a correlation. So it's a fetal impact as well as a newborn, toddler, and childhood impact. And as I stated, we just don't have enough of us participating in clinical trials. But I imagine if we could get more participation in clinical trials, we would come up with more alarming statistics.
Well, thank you so much. Uh, is Dr. Lawson with us today?
He
Dr.
is.
Lawson is here.
And Dr. Lawson, will you take the next slide if you don't mind? Let's skip this one. Yeah. Can you see this one?
He's muted.
Can I just add to a point that Dr. Rayford made about, obesity? And so when I was in medical school, it was, obese parents have obese kids because they have the habits, of obesity, right? So their household and the way they move, right? That was the reason. But just to be clear, that's not the only reason, which is what I think Dr. Rayford was getting at. That's not the only reason. There are actual that's what the data is showing. It's more than just behaviors that are being passed.
Yeah, thank Dr. Lawson, you get unmuted?
Yes, I am. And what I'm looking at is a slide showing prevalence of hypertension.
Thanks to go
And
back one slide, Simon.
but basically, this one shows the African Americans' prevalence, then the impact of therapies, impact of
Hold on. I
therapies
think,
on
okay,
CVD
I'm gonna go
hospitals.
back. Dr. Lawson, go back. There's two sides. Go back two sides. That one.
And then we look at CVD mortality of African Americans versus US. And basically, what we're showing is that the US population is way below what African Americans are. CVD is consistently high. And you look at the year, what's disturbing is that while there has been a drop, unfortunately, the gap has not closed. I don't think this is a significant difference. Has not closed very much at all.
And take the next one if you don't mind. Next slide,
Sure.
Simon.
And combined with hypertension prevalence, again, African Americans hypertension rates much higher than the U.S. population. And this is a little disturbing because over the 20 years, um, um, both the U.S. population and African Americans have shown an increase in terms of hypertension prevalence. However, for African Americans, again, there's a significant gap. It's been interesting, by the way, if you looked at data from West Africa. But the point is, as you know, we don't find this as strong a difference when we look at West African population until very recently when they began to develop Western lifestyles and Western diets. And I also want to just follow through what was previously said. No, it's not just eating, but also exercise. We are a very sedentary people, and unfortunately, it has not changed very much at all. You focus on elite athletes, but the average person, frankly, spends most of their time sitting on their butt playing video games and watching TV.
Thank you very much. Dr. Hind, if you take the next one, and Dr. Neighbor Stevens, the one after that.
So the impact of therapies on cardiovascular disease. So the standard, if you consider the standard care, the rate of hospitalizations is 100% for cardiovascular disease. So that's going to be our baseline, right? So when you compare using GLP-1s, that's the Wegovys and the Mounjaros, then that takes the risk of being hospitalized for cardiovascular disease down by 20%. And then the SGL2s, they're just a slightly lower, they reduce it even more. And then the Corindia, the non-steroidals, they reduce it even more. So if you were on, let's say, a combination, and I'm not sure if this is saying if this is used individually or in combination, but you could reduce your risk. Using one of those therapies could reduce your risk of having a hospitalization related to heart disease to as low as roughly 70% or so
And
compared to standard medicines.
I typically use all three of them together. The
Yeah,
one,
now again, I don't know if the graph is showing it collectively. I think the graph is saying their impact individually. I'd be interested to see, to your point, what happens when you combine them, or do you kind of plateau at a certain point? Who knows?
right now, I'm hoping that they don't plateau.
Yeah, hoping for an additive effect. Yes.
That's Neighbor Stevens. You go to the next slide.
Lifestyle modifications. So the DASH diet, which has been around now at least 20 years.
And tell them what the DASH diet is.
It's basically a Mediterranean type diet. Low sodium, high fruits and vegetables, whole grains, and non-fatty meat.
Is meatloaf in that?
I thought they could have chicken.
Yeah, you could, right? You could use ground turkey and stuff. You could make a healthy meatloaf.
Yeah.
Okay.
Regular
That was a private
exercise.
joke. I always asked Dr. Neighbor Stevens to make me some meatloaf.
Regular exercise, going back to the comment that Dr. Lawson made, we tend to be a sedentary population, and exercise seems to have a very positive impact on all kinds of things, not just cardiovascular disease, but also on the brain. The brain likes for you to exercise. Weight loss. Well, if you're obese, you need to lose some weight. So it stands to reason, although it has been proved scientifically, that loss of weight, and not really a whole lot, just between 5 and 10%, improves your blood pressure control. It also has been shown to decrease and sometimes eliminate the need for uh, medication treating diabetes. Limit the alcohol. This is really getting quite the conversation these days. It's really it seems like what they want to say is you should not drink. But they can't quite get to that point, so they're saying maybe an occasional one. But definitely we got the science to show that you need to quit smoking if you're smoking. And all of us need to manage our stress. Now, we had a quickie question that flipped up, and it was a good question. What is the role and impact of coffee?
So I can help with this one.
Go ahead.
Well, I was going to say, so caffeine in general There is a role there. So moderation. So what the equivalent of 2 to 3 cups of coffee a day is around the space where the average healthy adult can consume coffee and not get any of the potentially negative side effects. For people who have high blood pressure that is controlled, they typically are able to still consume coffee. For people who have high blood pressure that is uncontrolled, you're supposed to monitor your blood pressure and see what coffee does to you. And obviously the goal is to get your blood pressure to good controls. And then the impact of caffeine on blood pressure is supposed to plateau over time. So there is a space for coffee in a DASH diet. It's the other stuff that people put in their coffee that can sometimes make coffee problematic.
And I think we want to do a whole show on coffee because there's some good and bad points. I read an article on a disease called MASH, which is a type of liver disease, and coffee will be beneficial to that for fatty infiltration of the
Yep.
liver up to a certain point. So I think the jury's out on how much. I think I'm glad you brought that up. But I want to go back to when we were in school, Dr. Stevens, a couple of years ago. A lot of samples that we had of things that we wanted to preserve, which means they were denatured, were preserved in a jar of alcohol. So alcohol is something that kills stuff in vivo and preserves stuff. And I don't think you want your living body to be preserved. So that alcohol needs to get less and less and out the back door. But a question to Dr. Lawson, with the dietary approaches to stop hypertension, which is a DASH diet, and regular exercise, I read an article that we used to have a target of 10,000 steps a day. And I read that after about 3,000 to 4,000 steps, there's no more gain in cardiovascular benefit. But we have something that happens. What happens to the brain with the exercise that makes stroke less there, makes adjustment mentally better? How does exercise help the brain?
Well, in many ways, but the main thing it does is that it actually in, uh, increases some of the arterial risks in terms of reducing stroke by allowing the vessels to be less rigid and more flexible. Also, what we've now find is that neurotransmitter activity tends to be more regular in terms of people who have exercise. People who do not have exercise, you find that especially the catecholamines tend to have peaks, highs, and lows. And we have this effect, especially, and you mentioned an effect of coffee or other stimulants. What we find is that they tend to produce highs, but then when you stop them, it's a big drop. And this is not very good with the brain at all. And now we're again finding a lot of evidence that amyloid production and some of the other factors that contribute to Alzheimer's seem to be much more result in terms of a lack of exercise and the inappropriate diet. There is a major study going on at Howard University, has been going on for a while now, showing that exercise, and they use PET scan data in which they actually track the amyloid accumulation, showing that diet and exercise can actually reduce the amyloid production. And well, it's still a bit early, but I think the evidence has suggested that it's going to have a positive effect in terms of risk for Alzheimer's.
Thank you so much. Next line, I'll take the
Yeah,
next one.
and sir, if I may also mention one other factor, you talked about um, coffee, but you didn't say much about some other drugs that are and some other recreational drugs that people are using. One of them is we mentioned last time is cocaine and marijuana. There's now emerging evidence that marijuana does not avoid the negative effects that we formerly saw with cigarette smoking. We are finding that people who are heavy pot users, that they'll be, and also vaping. We begin to see some of the same kinds of consequences that we used to see with heavy cigarette smokers. And unfortunately, that message has just not gotten out at all. And we're now finding, especially for females, increased risk of drugs such as marijuana and others in the African American community. Even though cigarette smoking is not as high in the African American community. Problem is that when we do smoke, the consequences are much worse.
Thank you so much. So the pharmacological therapies that we recommend. As first-line therapy, we use sometimes thiazide diuretics, ACE inhibitors, angiotensin receptor blocking agents, things that end in the word sartan, calcium channel blockers, such as amlodipine. I tend not to personally, in my office, use thiazide diuretics. I use more hydralazine combined with an ACE inhibitor and ARBs and calcium channel blockers. I don't use ACE inhibitors in blacks either. And also, the choice does depend upon comorbidities, whether they have diabetes, coronary artery disease, or CKD. And usually, I look for drugs that are in combinations so that they don't have to take 4 different pills. They can take 3 or 1, where things don't have the side effect profile. And also monitor them for adherence and make sure they're below the side effect profile. Next slide. So we know that hypertension is strongly linked to CKD and cardiovascular mortality. Early intervention reduces progression of kidney disease, and we want integrated management of blood sugar and cholesterol. A lot of people don't like to take the anti-cholesterol drugs; they're afraid of cramps. But I think you'd rather have a cramp than a stroke. So there are a lot of different cholesterol-lowering drugs you can try, but it's always best, and the studies with Kaiser and other groups have shown that it's very important to keep that cholesterol as low as possible. And let's go to the next slide. Dr. Hines, you would take this one?
Sure. So CKM syndrome and what you want to track. So you're going to want to track your vitals. That's your, your pulse, your blood pressure, the anthropometrics. So now you have home monitors for some of these things like home blood pressure cuffs. Your BMI is that, ratio of your weight for your height, and then your waist circumference, as I was talking about earlier. And then the metabolic components, these are things you're going to need labs for. We talked about your fasting glucose. It should be less than 100. Checking your A1C, your lipids, which is your cholesterol levels. And the total cholesterol is only part of the picture. You want to know the combination of numbers between your good cholesterol, your bad cholesterol, and the ApoBs. There are other markers for cardiovascular disease that need to be checked, especially if you have a history of heart disease in the family, because that standard lipid panel may not show you some of the things that are important in that space as well. Kidneys, your glomerular function rate or your GFR, how much, is there any protein or albumin in your urine? And then other things like we've spoken about before, tobacco, physical activity, diet. I just want to speak a little bit about sleep apnea. Sleep apnea initially, I feel like it was marketed as, you can, the annoyance of snoring, right? The ways that snoring bothers other people. But now, or even makes you tired, right? Fine. Now we know that sleep apnea, untreated sleep apnea, has other significant consequences, including, if you have difficult to treat high blood pressure and you have untreated sleep apnea, that could absolutely be an issue. It raises your risks for other chronic diseases as well. So just making sure that you treat that sleep apnea, even if it's not because you feel tired, right? Or you think you don't feel tired.
Is sleep apnea related to obesity in some cases?
In some
Yes.
cases it is, but it does not have to be. You can be a moderately sized person, a thinner sized person, and still have sleep apnea. Anything that leads to obstruction in that airway. So if it's big tonsils, large adenoids, heavy chested women in particular, if you have large breasts and when you lay on your back, that is causing you some, obstruction there, because it's just weight, right? And it makes it harder to breathe. Any of those things can be contributors, physical contributors to sleep apnea. Neck circumference is one of the things that your doctor might look at. And then the other thing is when you open your mouth and do the right? Can you see the opening, or does it look like your tongue is right there at the roof of the back of your mouth? That's some of the things that we look for on a physical exam to suggest sleep apnea, especially for people who aren't complaining about having it.
And two things that you said are important. One, we used to put chocks under the bed, under the head of the bed, raise the head of the bed a few inches so you're not laying exactly flat. That would help some with that sleep apnea. And also, you mentioned say ah. I was always taught to say ah.
Well,
And
I
you
didn't want to stick my tongue out at the.
could. Let's go to the next slide. I'll take it.
Dr. Maxey, I
Yes, sir.
want to make one other point. Sleep apnea is clearly a big risk factor for depression. And when I see people with major depression, I always ask them, are you snoring? Are your partner complaining? You really need to ask, see, if, especially for obese people who are depressed, have you had a sleep study? The other point is that it is associated with other conditions such as COPD and maybe a risk factor for Alzheimer's as well and other dementing disorders.
And Dr. Max, I have a question too concerning sleep apnea.
Yeah.
And Dr. Hines, are there other ways of treating sleep apnea other than CPAP? If somebody could talk about that.
There are multiple ways of treating sleep apnea other than CPAP. So right now there's something called Inspire. It's an implant that kind of it's an implant that will kind of give your tongue a little bit of a stimulation while you're sleeping, not enough to wake you up so that it can stop moving to the back of your throat. That is one. There are, depending on how severe your sleep apnea is, there are like mouth guards and things like that you can wear. Again, depending on how severe your sleep apnea is, even elevating your bed, changing some of your nighttime habits. So for example, if you're a drinker, right? And you find, and this is a common one, sometimes your drinkers, when they drink, and then they have sleep apnea, right? If they don't drink, then sometimes those muscles don't relax that same level. That can sometimes be a treatment in and of itself. So there's also a surgery that can be done for some people. So there are multiple different things, again, depending on the level or the severity of your sleep apnea, and then where is your obstruction? What's the root of your obstruction?
Thank you very much.
Thank you. Let's skip this slide. Let's go to the next one. So let's talk about guidelines a moment on high blood pressure. So we know that the categories are not changed in the new guidelines that just came out a couple of weeks ago. Normal blood pressure is less than 120 over 80. So 140 over 80 is not good. 135 over 80 is not good either. There's something called stage 1 hypertension, which is 130 to 139 systolic and 80 to 89 diastolic. And systolic is the top number in blood pressure. Diastolic is the bottom number. Stage 2 hypertension is 140 over 90. So these numbers are very important, so don't get fooled. I get many patients referred to me from doctors who don't know how to take care of Black people saying, you're Black and it's okay if your blood pressure is 140 over 90. It's not. That leads to problems. We also know that the guidelines say start the medications earlier if it's any greater than 130 over 80. And I would not wait if that person has either CKD or diabetes. I would start immediately. Otherwise, I might wait 3 to 6 months to make sure lifestyle changes can't do it, and then you don't have to do medicine. And also, we want to consider GLP-1 for patients with hypertension if they have obesity or if they have diabetes. I would start adding those other medications as well. And we know that, as the doctor said previously, and Dr. Rayford, that if you're pregnant, you want to treat that. And there's certain medications that are better for treating pregnant women. Would you speak on that, Dr. Rayford? Can you unmute yourself?
Okay, yes. Typically, the beta blockers tend to work very well, and the calcium channel blockers. We tend to use a lot of labetalol, um, calcium channel blockers, amlodipine, nifedipine. They tend to work very well and are tolerated well by the fetus. And as you see in pregnancy, unlike non-pregnant state, uh, we don't generally treat until it's greater than 140/90, as opposed to 120/80. And the rationale for that is uteroplacental perfusion, which means that patients, particularly those who have already been hypertensive, if we drop their pressures too low, or what we call gold standard right now, 120/80, then uteroplacental perfusion is compromised. And then we end up with problems with the fetus. But this is one of the things we run into. Patients are quite perceptive. And they'll say, oh, well, while I was pregnant, I wasn't treated until I was at this stage. Now that I'm not pregnant, they begin to feel, oh, that's fine for me. And then we have to go through the counseling again that, well, now we're in the non-pregnant state and we are trying to go back to the normal standards, 120/80, which is difficult to do, I tell you. It's difficult.
Thank you very much. Dr. Nicholson, would you take the next two slides if you would?
Lifestyle and diet, big wins for blood pressure and chronic kidney management. We want to aim for taking in less than, equal to or less than, and I emphasize the less than, 1,500 milligrams per day of sodium. And try not to get, I think this slide is trying to say, try not to get up to 2,300 milligrams a day. And the way to avoid that is by controlling your use of salt, either at the table or when you're cooking. But probably the biggest contributor to sodium intake is the hidden sodium in all kinds of foods. So you have to become a compulsive label reader to make sure that you know. For example, pick up the regular can of soup. That can of soup will probably have anywhere from 650 to 870 milligrams per serving of the soup. So, and then salt can be in places you wouldn't expect. I frequently use the example when I was pregnant with my first child, I stopped using salt because I started having some swelling in my feet. Once I stopped using salt, I discovered that the nuts in butter pecan ice cream were salted. Who would have thought it? So you really have to be a label reader. We talked a little bit before about the DASH or Mediterranean style diets, where you consume more potassium rich foods unless you have chronic kidney disease. We want physical activity, trying to get at least 150 minutes a weekend that is made up, that consists of moderate exercise and 2 days of resistance exercise. Why? Because you want to keep your muscle mass up. And that's particularly true in the elderly. Weight loss, 5 to 10% can help lower your blood pressure and improve your hemoglobin A1C. Talk to your doctor about programs that might be available. We've beat this horse to death. If you're smoking now, please try to stop. There are aids out there that can help you. Nicotine patches, there's behavioral therapy, or there's cold turkey. Uh, we want to
What about low sodium soup? Does that help?
generally they have around 470, 350 to 470. Reason I know this, I just recently was looking at cancer soup. Uh, you want to limit your alcohol and you want to, and this is really important. We haven't talked enough about this. You need to get your sleep. And Dr. Lawson has been talking to us about the impact of stress on and how we need to reduce stress and improve our stress management strategies.
I'd just add two things to this talk about lifestyle and diet. Someone put in the chat if it has more than 500 milligrams of sodium in it or in a serving, they don't consume it. So and the other thing I would just point out is, especially when you're trying to lose weight, right? And you think I'm going to go to these low fat things. The low fat things often have higher sodium because they are marketing for taste, right? So just something to be mindful of when you're trying to make healthy food choices. The other thing I will say is, because oftentimes I talk about AI and technology. So AI is not a replacement for your doctor. There was a recent story about a gentleman who had hypertension and was trying to reduce the salt in his diet. The sodium chloride is table salt. AI told him to switch to sodium bromide, right? Which he did, and then ended up severely ill, hospitalized with psychosis and the like. My point there is saying the computer searches are just that. They are a way to look for the potential for information, but right, they are not a replacement for a person who understands your doctor understanding the full context of your medical situation, the full context of what's going on in the human body. So just pointing that out, because again, it is natural to want to look for information on how can I do better. As well you should, but before you make any radical changes, talk to your doctor.
Thank you very much. You will take the next slide. Dr. Hines?
Oh, I'm sorry. All right. So medicines that change outcomes. We talked about the GLP-1s here. So semaglutide is one of them, and it can reduce your risk by your relative risk by 20%. Some of the SLGs, the flozines, can reduce your risk by anywhere from 44 to 28%. And then the non-steroidal anti-inflammatories we talked about can reduce your risk by 18 to 13%.
Okay, let's go to the next slide. I'll take this one. So these are algorithms that we want to suggest that you first screen, we're going to stratify, and then treat the person and track them. You have to keep up with them. It's not you see them once in your office or you go to the doctor once and you're finished. You have to be checked. I tend to check people until their blood pressure gets normal. Then I may see them every 3 months, but not until I see it go to normal. And I always ask when they come into my office, have you had caffeine today? Because that can artificially elevate that blood pressure. And I make sure they're drinking adequate amounts of water so we don't get a false picture of orthostatic hypotension as well. So you first confirm they have hypertension and you want them to bring their home monitor. Everybody should have a home blood pressure monitor. And not the kind you put on the finger, not the kind you put on the wrist, but preferably on your upper arm. It's very important to do that. And you want to stage their risk and find out what's going on with them. And we're going to take their A1C, their glomerular filtration rate. And most importantly, we want to look at their protein in the urine and look at their cholesterol level, especially LDL and the LDL-C, which you only have to do once a night because it doesn't usually change. We start everybody with lifestyle change in management. They should be eating better, exercising, as Dr. Neighbor Stevens was saying before. That goes for everybody. And then on top of that, you start their medications if their blood pressure is greater than 130 over 80 after 3 months, or immediately if they have either cardiovascular disease, CKD, or diabetes mellitus. Don't wait. Start it at that point. So if your doctor is telling you to wait 6 months before he treats you and you have diabetes, tell him he needs to do work better and do something different than that. So first line, again, some people say thiazide diuretics. I personally don't use that much in my practice at all. And I use the calcium channel blockers and ARBs, more importantly, especially those that have albuminuria. And I use the SGLT2s, and if they have diabetes and consider GLP-1s, I use all three of them together. And I counsel my patients to keep up with me, and maybe I'm seeing them too frequently, but I'm very scared of high blood pressure. Next slide. Dr. Lawson, we take this one?
Sure, equity actions that improve blood pressure control provide validated. When it is validated to whom blood pressure cuffs, some of this stuff on Amazon not been validated. And frankly, several studies have shown that they're virtually worthless. Teach technique, telehealth check-ins really has been an important contribution in terms of making access to care for folks who can't get in. Medication affordability, and we can have a long discussion on that. Generics, patient assistance, 90-day fills, community partnerships, barbershop pharmacy, blood pressure programs, and also it also surprisingly we should have this. Mental health clinics don't have often don't monitor these kinds of things. Churches, sororities, fraternities, where people are is when we should get these assessments. Address food access, transport, and I again make the point before. Too many of our communities do not have grocery stores. Even some of our very wealthy African American communities. Food access, transportation. It's very easy to run down to the 7-Eleven and get a soda pop than it is to go to find a market that has fresh fruits and vegetables or go to a farmer's market. And caregiver support in care plans.
Thank you. And the last slide, if you take this, Dr. Hines.
So takeaways for patients. So most importantly, know your numbers, right? Know what your blood pressure typically runs. If you've been tested and had a hemoglobin A1C, if you are a diabetic, you should absolutely know what your last hemoglobin A1C was. Know your eGFR, which is a measure of how well your kidneys are functioning. Know if your doctor has checked you for protein in your urine with a urine albumin test. If you have some of these chronic conditions, your doctor should check for those things, and you should be able to say, have you checked me for that? And they say yes, right? Your LDL, that's your bad cholesterol. Know that these things have been done for you. You want to aim for a blood pressure less than, I'm going to go with 120 over 80. And then bring a home blood pressure log to your visits. There are apps that will log your blood pressure. The machines will log your blood pressure. You could get a pen and paper, log your blood pressure. Some of the stuff will even transmit the information directly to your provider. There's a whole lot of ways for you to be able to go to your doctor's office and tell what your actual blood pressure is in your real life. So all the people running around thinking they have white coat syndrome because their blood pressure is high at the doctor's office, prove it, right? Prove it with normal numbers at home. Cut down on your salt, move more, sleep better, and even small amounts of change can be helpful. Ask your doctor about SGL2s and the GLP-1s and finerenone if you have diabetes or kidney issues. And then continue to follow up, right? Make sure that your blood pressure stays controlled, because again, this happens too. People got to a goal, right? And then they stop going to the doctor with any regularity. They stop checking their blood pressure at home with any regularity. So it's important to stay consistent with making sure that you are as stable as you think you are, because blood pressure control prevents strokes, dialysis, and heart failure.
And just to be complete, the last slide, Simon, this will show up on the Zoom.
And these are our references. Again, we use validated information and resources on the Black Health Trust, not necessarily what's popular in discourse as our sources for where we give advice from.
All right, I thank you so much. Are there any questions in the chat or any comments in the chat before I have a final thing I want to speak about? That's Neighbor Stevens?
I am looking. I think we've addressed most of them. I'm just double checking.
So there are some comments I see about how participating in yoga can decrease your blood pressure, as well as Tai Chi.
I think
I
we
like
got
Tai
all.
Chi.
I think we touched on all of the questions.
Okay. So I had a long talk with our resident pharmacist last night. Not a long talk, but a significant talk. And he had some comments about us possibly needing to use a better medium than Zoom. Dr. Gibson, are you on?
I am.
Would you give a brief comment of your thoughts? And
Well, there has been some, not just a little, but quite a bit of communication about how platforms like the current one that we're using right now um, tends to be audited even involuntarily, whether we want it to be or not, by some chatbots that will go unnamed at this particular point. But I think it's important for us to be mindful of, excuse me, whatever guardrails we can use, because I cannot say with any degree of confidence that there is even such a thing as privacy anymore. But what I suggested, maybe those of us that use these various platforms might consider doing is offering some suggestions of those other options that perhaps we might begin to look at as as possible alternatives to the current platform.
thank you very much. So what I'm going to do is convene a meeting with Simon and my co-moderators in a week or so, and just come up with some suggestions about what we might need to do. Thank you for bringing that up. And I thank everybody for joining us today. I think we had a very good session. So watch your blood pressure, and even take your blood pressure cuff to your office, to the doctor's office, and make sure you're using it right and it's coordinated and it's correct information. I don't know if you should put it over your suit coat or your with the blouse on. I think it needs to be on your bare skin to get a good reading. Dr. Hines, you might want to comment on that.
So sure. I was always trained, certainly bare skin is ideal. If your shirt or blouse is very thin, right, you could potentially get away with that. But other than that, if it's a sweater, no go. If it's a sweatshirt, no. A coat, no. Right? Like if it's your regular thick cotton, no. And then also, you also have to be careful about pushing up your sleeve, because if you push up the sleeve, right, so that it's, high enough so that the blood pressure can fit on, you're also potentially altering the result. So in the ideal world, even you can just take that arm, especially as you get to colder months, take that arm all the way out of that sleeve. You're not exposing yourself. You can still keep your shirt down, right? And then do the blood pressure cuff, 2 feet on the ground, not floating in the air, right? 2 feet on the ground, with your arm resting on, the armrest of the chair or whatever, right? The reality is the majority of us, and when we're going to the doctor's office, are not getting our blood pressures taken properly. Lots of people are just, we're checking boxes, right? And we're not doing all of the steps to make sure that we're getting accurate blood pressure readings. And both arms is ideal, right? Because again, there are problems when one arm is reading differently than the other arm. And the only way you would know that is to check both.
Well, thank you.
So if you're getting your blood, can I just ask, if you're getting your blood pressure checked, which arm should they use, the left or the right? I've read somewhere that you should use your left arm for checking your blood pressure.
So in a healthy individual, they should be the same on both sides, assuming that you haven't had, some type of surgery or procedure. Usually, the only time somebody will have a not use this arm is because they've had some type of surgery or some type of procedure
Or
on
takes away
an
on the
arm.
leg.
But they should be the same on both sides.
Correct. This is a quick round of final comments, starting with Dr. Lawson. We'll go through Dr. Lawson, a brief
Yeah,
comment.
again, want to make the usual. I mean, I mentioned the PHQ-9 and GAC. These are screeners that many primary care folks have in their office, but do them and they ignore the results. These are risk factors for depression and, I mean, for diabetes and hypertension. And sometimes improving that PHQ-9 GAC will lower blood pressure and get the blood glucose under control. And also, we talk about institutional racism, blah, 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 blah. Bottom line is when you're in a setting that you're a stressful setting, go back and check your behaviors and see what happens when you come home from that toxic work environment. See if there is a change in terms of what's happening in terms of your vital signs.
Well, thank
So
you.
these are things we can do something about. And it's important to get that meditation or the Tai Chi or yoga as much as as much as some of the other interventions as well.
Dr. Hines?
My 2 cents is don't get complacent, right? If you're going through the effort of taking these pills, right? If you're taking your blood pressure pills or you're taking your cholesterol pills, or whatever, taking your shots, whatever it is, take them until you get to the goal. Don't get satisfied with better.
Dr. Barbara Davis-Stevens?
Well, thank you for sharing this hour with us. We are trying to give you the tools so that you can try to take better care of yourself than you've been taking, because we need to stay as healthy as possible.
Thank you all very much. Have a great, great Sunday and keep your blood pressure in control. And thank you, Simon, for today. And thank all
Dr.
of
Maxey,
Dr.
just
Georgia.
one question. I know you all talked about hypertension, but what are the indications for taking the blood pressure sitting in line? That may be another whole topic. And the other thing, we haven't talked about hypotension because that's also a major problem. So maybe that's something for the next meeting.
We'll do it coming up next week. Is going to be Dr. Walks. He's going to be fresh from his cruise in the Caribbean.
Oh, really?
I hope he's not getting too wet in the hurricane that's out there. He's celebrating a 90th birthday of one of his uncles, so we just hope he's safe and having a good time.
Yeah, that's wonderful.
Have a great day, everybody. Thanks for joining us.
Mhm.